Okay, it looks like we're sort of maxing out on voting. So it looks like the majority of participants here today are in agreement with both of the statements. We'll see after the debate. Okay. We'll see after the debate if any of this changes, but it seems to be a clear majority in agreement with both of these statements.
It's very unfortunate. I wish the bar had been set quite low.
No pressure, no pressure. All right. So I'm going to introduce the first speaker, Dr. David Warr, and then I will introduce Carlo DeAngelis, who I know quite well. So Dr. Warr is only recently retired as a medical oncologist, breast medical oncologist at Princess Margaret Hospital, but he is still associated with committees there. He has conducted multiple studies in supportive care, especially antiemetics. He's a well-known name in this area and has been the clinical lead for Cancer Care Ontario antiemetic guidelines and also has been involved with the Multinational Association of Supportive Care in Cancer, or MASC antiemetic guidelines. He is a past president of the MASC organization, or Multinational Association of Supportive Care in Cancer, and recipient of their Distinguished Service Award. Please join me in welcoming Dr. David Warr.
Yeah.
I guess we can do this virtually. You can clap your hands on the emoticon thing. Now, as far as Carlo DeAngelis goes, well, I've known Carlo. He's been a friend and mentor for more than a decade. He's been involved in numerous supportive care studies, topics, issues, has been past president of the Canadian Association of Pharmacy and Oncology, is a currently clinician scientist here at the Cancer Center at Odette, and he will be presenting the con side, I guess, if you will, of the debate today. Please join me in welcoming Carlo. All right. Dr. Warr, I will leave it to you to share screen and start your section. Now you have 8 minutes to lay down your case, as it were. Then Carlo will have the same, and we will continue after that.
All right. And you'll have to let me know whether this is showing.
It is showing, absolutely, yeah.
Okay, that's great. Well, thank you very much. This should be fun. So I'm on the pro side of the debate, and it's as a result of this article that appeared in Supportive Care in Cancer, where I was one of the co-authors, that went after reducing dexamethasone as antiemetics. And this could get quite complicated because the 2 points that we're asked to debate are quite wordy, and it really could break down into about 5 different questions in 8 minutes, which is a little unrealistic. So I'm going to reduce this down to why bother reducing dexamethasone, and how can we do this in a way consistent with the published evidence. Basically, what we want to talk about is using the lowest dex dose shown to be maximally effective. And I think COVID-19 provides an opportunity to do something that we should have done already, that is reduce the corticosteroid and hopefully reduce problems such as insomnia, agitation, heartburn, perhaps weight gain, especially in breast cancer. And disturbing to me was the 10 to 20% incidence of new onset diabetes, let alone flare of pre-existing diabetes. So the first issue is, can corticosteroids predispose to COVID-19 or its severity? And unfortunately, data with low-dose steroid use in other conditions suggest possible harm. It will be impossible to test it in the antiemetic area, and this is necessarily data of a non-randomized nature. And it comes from international registries, one in rheumatic disease and one in inflammatory bowel disease. The one in rheumatic disease was 600 patients from 40 countries. They did a multivariable adjusted model using multiple aspects of comorbidity, modifying factors, and they came up with an odds ratio of 2.05 for a higher odds of hospitalization with COVID-19 confidence intervals not overlapping 1. And in the inflammatory bowel diseases, again, a similar kind of analysis, but with a different endpoint. They were looking at risk factors for severe COVID-19. And what they called severe COVID-19 were patients who were admitted to ICU, who were on a ventilator, or who actually died from COVID-19. And by far, the strongest risk factor was pre-existing corticosteroids, current corticosteroids, with an odds ratio adjusted 6.9. So there is some evidence for harm. So if we're that fanatical about getting rid of dexamethasone, why do we say dexamethasone beyond day 1 is still necessary for cisplatin? Well, there is some good evidence for up to 4 days of dexamethasone with cisplatin in the era pre-NK1 receptor antagonists and olanzapine. And there's one recently published study that I'll show a table from using palonosetron and netupitant, i.e. a modern NK1 study. And it does show a trend, a strong trend in favor of using day 1 to 3 dex over just day of treatment dex, although the numbers are small. And for that reason, we didn't extend the day 1 only dex mantra to cisplatin, which that chemo can be quite toxic if the nausea is not controlled. And this is a study by Ito and the JCO. And this is the relevant table for the cisplatin subgroup. The primary endpoint was complete response over the first week. And you can see there's a numerically higher response rate on the number on the right-hand side for 3 days of dex versus 1. And the absolute difference was 9 with wide confidence intervals. Now, this is an insufficient sample size, and I'm not sure whether it was actually a planned analysis, the authors didn't say, but it is compatible with earlier positive cisplatin studies. Hence, we said to keep dex as per the guidelines of MASC and ASCO. So why discard dex beyond day 1 for non-cisplatin chemotherapy, provided that palonosetron is used? Well, there is one very large Italian study from 2 decades ago that shows a statistically significant benefit for dex beyond day 1. And this was in a patient population that they said was either an anthracycline or cyclophosphamide or carboplatin. And giving dex beyond day 1, days 2 to 4, provided an absolute 11% higher benefit in the primary endpoint of no vomiting and mild nausea. Now, but they did use a short-acting day 1 ondansetron, and that may influence the results. Plus, it is prior to NK1 receptor antagonists, which, as we all know, decrease delayed nausea and vomiting. There are no other data that I'm aware of that show a statistically significant difference by extending dexamethasone, except for the cisplatin studies. So where does AC fit? There's no guideline change, no dex beyond day 1, and there are 3 randomized trials that demonstrate with palonosetron, day 1 dex suffices. And it's unknown whether shorter acting cetrons on day 1 are sufficient when you limit the dex. And in the original aprepitant study in breast cancer that I was involved with, that changed guidelines, 3 days of ondansetron were used. Therefore, use palo because it's at least as good as short-acting agents. The other discussion point was for regimens with low emetogenic risk, 5-HT3 receptor antagonists are recommended over dex. Now, this is an evidence-free category, and guidelines say both are options. Yes, ondansetron is more expensive than dexamethasone, but this is a temporary increase in cost. Or as per the MASC guidelines, you could use a cheap dopamine receptor antagonist. Now, did we miss going even further? Should we go even lower than the standard 8 milligram dex on day 1 for non-cisplatin chemo when NK1 receptor antagonists are used? Remember, NK1 receptor antagonists double the blood level of dexamethasone. Hence, OPUS has a 50% reduction in the dex dose when you use an NK1 receptor antagonist for AC or cisplatin. The critical question is, what is the lowest effective day 1 dose for non-cisplatin? And again, the Italians came to the rescue. They did a study where they compared 3 doses of dexamethasone, 8 milligrams single dose, 24 milligrams IV, or a split dose over 24 hours with 20 milligrams. What they found was that dexamethasone 8 milligrams single IV was as good as anything else. Now, dexamethasone, you might say, okay, this is actually what we do. Your pharmacist will say, that's the dose we use. But if you also used an NK1 receptor antagonist, as with AC or carboplatin, you use twice the necessary day 1 dose. That is equivalent to about 16 milligrams of dex. So in summary, reducing dex is desirable and it's supported by data. Palonosetron is preferred when sticking with day 1 dex for emetogenic chemotherapy. And if you're using palonosetron and needing an NK1 receptor antagonist, why not prescribe netupitant, as our guidelines suggest? Because limited use coverage is the same and it is more convenient. Thank you very much, and happy holidays to everyone.
Thank you, Dr. Warr. Carlo, DeAngelis, it is your 8 minutes up. I'll set the timer, and if you like, I can give you a warning. Dr. Warr, you were bang on time. I suspect Carlo will also be bang on time, but if you would prefer, I can give you a warning. You gotta take yourself off unmute. You have to unmute yourself.
Yeah, thanks, Mark. Sorry,
Yeah,
give me
no
a warning and just.
Did you want a warning?
Yeah, please.
Okay,
And,
2 minutes.
I would, yeah, 2 minutes. I would actually put my bet on Dr. Warr as well, just so everybody knows. Anyway, I took a bit of a different approach for today's talk. I'm sorry, it's not advancing. Yep, there we go. And answering a couple of different questions, and what Dr. Warr answered in this previous in the talk. So I think there's a number of issues when it comes to just cancer patients and COVID. And so the first question is, are they at increased risk for COVID-19 infection? And really the premise behind this is pictorially shown here, where you have increased presumed immunosuppressive state with, as you move from cancer diagnosis, surgery, relapse, treatment, and then to metastatic disease. And as disease progresses, your immune state is much more suppressed, and presumably you're much more susceptible to the SARS COVID virus. So there's not a lot of data prospectively in this setting, although it is coming. And I have to say the British have done an amazing job in terms of studying COVID in cancer patients. This is a meta-analysis of a study looking to see what are the underlying diseases in patients who are admitted to hospital for COVID-19. And basically they started with about 900 studies from the literature, and after exclusion criteria, et cetera, evaluated 10 studies. I'm just going to show you one plot, and this is the prevalence of cancer patients within the whole cohort. So basically at the bottom here at 0.92, about 1% of cancer patients, 1% of patients admitted to hospital for COVID-19 were cancer patients. So to me, this seems like a low prevalence. It's 10 times lower than cardiovascular disease patients, diabetes patients, and elderly. So what about the question of, are patients at increased risk for complications? Because of course, we're worried about that as well. And here again, the data isn't that clear, although this is a really interesting study coming out of the UK. It's a population-based study where there's primary care physician software records patient information. Basically the study population was 17 million Britons. Of those 17 million, 10,000, almost 11,000 developed COVID. And I'm going to show you a close-up view of this one, but this is the hazard ratio for various components of the for various characteristics of the patient population. Ethnicity didn't seem to make a difference here in the middle. You look at diabetes. As diabetes gets worse, the odds ratios increase. But really what we're interested in is oncology or cancer patients. And so I'm just going to compare cancer patients here at the bottom to age group. And we can see that age really is a significant factor when it comes to death related to COVID-19. It really by far outstrips other hazard ratios. And this is a log scale. So this is in the range of 20 in terms of once you get to beyond the age of 80. Males are also more susceptible to dying from COVID, and we knew this as well. This isn't anything new. But what's interesting in this study is they actually broke down the different cancers from non-hematological to hematological malignancies. And one can see that in the non-hematological malignancies, that the greatest risk is that those patients at less than 1 year of age since diagnosis, presumably some of them still undergoing active treatment. The other interesting finding from this study is that clearly patients with hematological malignancies are at greater risk of dying from COVID once they get COVID. So clearly, for many other reasons, but including this, we obviously don't want our patients to contract COVID. This is a really complex study, but it's the UK Coronavirus Cancer Monitoring Program, where they've set up a database to prospectively follow cancer patients who are diagnosed with COVID. There's a sample size here of 800 patients. You have mild COVID-19, severe COVID-19 critical in the ICU and no information, and whether they went on to receive chemotherapy or not. And basically what they show here is that 35% of patients went on to receive chemotherapy, about 29% of them died versus 72% of patients, 72 patients that did not. And the hazard ratio for patients, and I'm just going to show you the top line here, the hazard ratio for patients chemotherapy versus no chemotherapy was not significant. So chemotherapy doesn't seem to worsen the outcome of patients. When you look at the different types of chemotherapy or what it's used for, it looks like patients who are receiving chemotherapy for palliative purposes are more likely to die from their COVID, which perhaps is not surprising. But other variables that they looked at here were not significant. The real answer is really going to come with the CAPTURE study, and this is again a UK study run out of the Royal Marsden, where they will be prospectively following a group of cancer patients from various centers across the country. This is the schema for the study. They're actually going to follow patients. Arm A are patients who have COVID-19 infection, Arm B without COVID-19 infection, and Arm C, the healthcare workers, with sampling being done for COVID-19, as well as biological samples in terms of the oropharyngeal swab, serum, peripheral monocytes, et cetera. And so they're going to evaluate basically what happens in this cohort. And I think we won't have the answer until this study is published. So dexamethasone sparing, are we measuring the right endpoints? And so Dr. Warr really nicely reviewed the data for dex sparing regimens. This is a study out of Europe and published in 2012 by Matty Apro, where they looked at guideline consistent CIMV prophylaxis and outcomes. And we can see from this, what this shows is that HEC regimens, about 43% are consistent with guidelines in the acute phase, 12% in the delayed phase, and overall only 11%. As we get to MEC regimens, they're more likely to be guideline consistent in the acute phase, but less so in the delayed phase, and this is sort of overall. So basically about half of the regimens are not, antiemetic strategies are not consistent with guidelines. And the importance of this is really the outcome. This is guideline consistent versus guideline inconsistent, and we can see that you're much more likely to have an event or at least not have complete response. That's no vomiting, no rescue medication, if you were not receiving guideline consistent antiemetic strategies. The other important thing that they mentioned in this study is that not getting good control increases resource utilization. And basically there are significantly more, or almost significantly more GP visits, but significantly more visits to specialists, significantly more ER visits and hospitalizations. And so what about dexamethasone sparing regimens? And Dr. Warr talked about the clinical trials. This is a meta-analysis of several clinical trials. And really, I just wanted to show, this is the acute phase response. So again, no complete response in the acute phase. We'll look at the top one. And basically it falls really on 1 when it comes to comparing dex sparing versus standard antiemetic. When we look though at the delayed phase, and here's what I think what bothers me about potentially not giving dexamethasone in the delayed phase, is that yes, the overall odds ratio is 0.92, not significant, but we're starting to move towards the side that favors 3-day dexamethasone. When we look at side effects, it's actually a little bit on both sides. There's less fatigue, or sorry, less anorexia, less asthenia in the 3-day dex group. There's more, not surprising, epigastric pain, hot flashes, and insomnia, which we would expect from dexamethasone. I think more upsetting, or for me, what really why I think dex sparing strategies can be deceiving, is that most CIMV trials report on the first cycle. And here's a study. It's a phase 2 study, and again, it's breast cancer patients, following them over basically 4 cycles each, 552 cycles. And what we see here, and this is NEPA, so this is again a dex sparing strategy where you just get palo, netupitant, and dexamethasone day 1. And what we see is a drop off in efficacy over time, from 70% after cycle 1 to 53% after cycle 3. And I think we may lose these patients if we're not careful with dex sparing strategy. And lastly, I just want to talk about the likelihood of subsequent CINV. This is a really interesting study, again, a database study out of the US, where they basically just looked at their patient population, patients that would receive LEC, MEC, and HEC, and divided the patients into 2 cohorts. No first administration CINV event versus a first administration CINV event. And they went on to look to see what was the likelihood of patients experiencing subsequent events if you did not protect them on that first cycle. And this is just their table 1. I'll just look at the far right. Basically, about 10,000 patients, 63% were female. Mean age was 61, although the MEC and HEC regimen patient population were older. That's a protective effect. And more of them were older than 65, again, protective in that patient population. They were principally breast and GI patients with respiratory and other cancers sort of spattered in there. And this is, to me, sort of like the slide or the data that really sort of, for me, would suggest that we need to be careful about how we use dex sparing strategies. And that is, if you look at LEC, if you had an event the first cycle, you were 3 times more likely to have an event in subsequent cycles. So whether that's LEC, MEC, or HEC, you're anywhere between 3 and 3.7 times more likely to have an event if you have an event the first cycle. So I think we have to be careful, again, with who we use dex sparing strategies in. And I'll just finish with this, is really just to, I think we need to individualize our approach to these patients. And this is a really practical guide to how we manage our patients with COVID. And I'll show you, direct you to the right side of the figure again. So really minimize hospitalization visits and elective admissions. And really there, if with good CIMV control, we can minimize that. We all want to do that, reduce exposure of patients. And of course, for all patients with active anti-cancer therapy, be vigilant with symptoms of COVID. And really the bottom line for me in this whole debate is really that one size does not fit all. And we need to get better at identifying patient populations who might truly benefit from a dex sparing strategy versus those that require a full 3 days worth of dex. And I'll stop there. And
great.
Yeah, we're good.
Okay, Dr. Warr, you have 2 minutes to rebut. Take it away.
All right. Well, first of all, great presentation, Carlo, but I think we need to subtract 20% off your final score because of the differences in time used, and add that to my score.
Okay.
Of course, the great leveler in all of this is olanzapine that's occurred in the last decade, and now oncologists are getting much more used to doing it, whether or not it's routinely put into opus. So it's become much more commonly used at Princess Margaret now. So it's an excellent rescue medication now and can be prospectively incorporated in the next cycle if you're too timid to put it in for cycle 1. So I think the data from the past is okay from an alarm point of view with what was being done then, but with good antiemetic practice now, I think the results are much better than what we used to see. At least that was my practice, where routinely for emetogenic chemotherapy, I would use olanzapine. The downside of corticosteroids, I think, were pretty well outlined in an article by Jeanette Vardy and Ian Tannock. So certainly in the breast cancer patients, they suffered a lot. So I think there are opportunities to reduce. I think our American colleagues are far less likely to use dexamethasone beyond day 1 than our Canadians are. And I think that's probably a good step in the right direction.
Thanks, David. I tried to actually rebut some of what you said while I was talking, but as we went along, I agree with you. I think olanzapine has really leveled the playing field, and as you know, we're very much an olanzapine center. They're built into our opus regimens. It's built into our opus regimens, and so certainly it would be interesting to see, the data when with respect to dose sparing strategies with the addition of olanzapine, either with addition of olanzapine. I think, though, one of the things that I didn't maybe say clearly is, our goal should really be prevention, the best strategy upfront, and prevention for patients, because as the last few slides I showed, that if patients fail the first time, they're 3 times more likely to fail in subsequent cycles, and we lose benefit over multiple cycles. And which is something that's typically not measured in CIMV trials, and we need to pay closer attention to. So I worry about using dex sparing strategies across the board, and whether we need to take an approach, as you're aware of this data as well, and I just didn't have time to present it, but Mark Clemens and George Dranaceris in terms of stratifying risk stratifying patients in terms of high and low risk emetogenic potential, and modifying your antiemetic strategy based on those risk stratifying steps. And they just published an article in the breast showing that in a randomized controlled trial that by identifying patients at high risk, these are breast cancer patients, and adding olanzapine to their antiemetic strategy, that those patients did better. So I think again, I really don't want to see across the board dex sparing strategies. I think we need to be more selective in terms of who we apply it to. I'll stop there.
Okay.
I could just comment on that one, the strategy of identifying low risk patients. In their article, they didn't actually identify low risk patients. The patients who were identified as low risk, I think it was 2/3 of them for the next cycle went on, or actually it was more than that, 75% went on to have an NK1 receptor antagonist added for cycle 2. So identified as low risk, but their actual outcome after cycle 1 wasn't that good. So I think the only predictor you can say is if they didn't do well after the first cycle, right, there's a fair chance they won't do well with subsequent cycles.
Right.
And that's where olanzapine comes in.
Yeah, absolutely.
Already.
Yeah, agreed.
Okay.
All right. Any other comments from either of you guys?
I think one advantage that the cancer patients have, although I never thought of it as an advantage in these times, is that they probably actually self-isolate now because they feel tired, they're nauseated, they're embarrassed about their hair loss. And I think some of us have convinced patients that they need to be germaphobes, that somehow washing their hands a lot will decrease febrile neutropenia. So that may actually play well into reducing their COVID-19 problems compared to the average population, even though their immunity is lower.
Interesting point. And it looks like Carlo agrees.
Yeah, I think educating patients in terms of making sure that they're isolating and just being careful who they come in contact with and is really critical. And PPE and all those interventions are really important for those patients. There's no question that we have a job to educate them, and I think for the most part they have been educated in the past, as you said, David, because of febrile neutropenia. But I think even more so now, we need to be vigilant in terms of how we educate these patients about protecting themselves.
Okay, very good. Thank you both for your insights and arguments. I open the virtual floor up to questions for both speakers. You can either unmute yourself or you can use the chat function. Well, not all at once, everybody. I actually have a few questions, and I don't know if either of you have come across this. We talk about dexamethasone or corticosteroids being able to reduce or I guess cause lymphopenia. At what point and at what dose would we expect this to be a clinical issue? We have data to suggest that these patients do worse, but at what point are we concerned? So is an 8 milligram dose going to suppress the immune system, and when would the onset be expected? And for how long might that be expected versus 8 milligrams times 3 days versus 8 milligrams times 1 day? Is there any idea about how the effect of dexamethasone or prednisone or another steroid, when the onset would be expected, and B, for how long the duration would be? And actually, I'll throw in C, to what severity would we expect that?
Well, I haven't seen any articles in the literature on that relating it to the duration of dexamethasone. It's a good point. And I can't say from personal experience that that means anything either. I have periodically looked for lymphopenia, even with non-chemotherapy approaches, when it's been recorded with certain other oral drugs. But I'm not unaware of any data that would answer that. And we haven't actually, I've never cut back on dexamethasone because of lymphopenia.
Okay.
I actually did go along that route to look at data for this talk today, and it's very limited. There's really not a lot there. There's some animal models, but I think the lymphopenia issue, is interesting when you look at COVID and its course, and this is starting to come out in the literature in terms of the progression of the disease. The fact that patients who become lymphopenic do worse may be a reflection of post-COVID cytokine syndrome or storm, and where patients may have already cleared the virus. However, because of their susceptibility to cytokine storm or cytokine release, they have this huge release of cytokines that then causes the attraction of lymphocytes and neutrophils and macrophages to the lungs, and leading to that respiratory distress syndrome. So it's sort of like, what comes first? Is it the lymphopenia that makes the disease worse, or is it the worsening of the disease that leads to the lymphopenia? And I think it's the latter, actually, that's starting to come out in the literature, that these patients, if you look at natural progression of the disease, as they're getting worse, their lymphocytes and neutrophils and other markers are dropping, but it's really as a reflection of the disease getting worse. And so again, I think we have to be careful how we interpret the data that's out there.
Interesting. And so I don't know if I looked myself. I tried to find the answer to this myself. I couldn't find anything either. Interesting. And so what about your thoughts on the use of GCSF, colony stimulating factors in patients who are at risk for, well, oncology patients who are at greater risk for worse outcome with COVID-19? Would you support the greater use of GCSF?
Well, again, so there.
Either of you, of course.
Yeah, I think again we go back to, identifying those patients who have potentially for worse outcomes, and I don't think we have a way to identify them yet. I think that will come as, other data comes out in the literature. I worry about increasing neutrophil counts too much. I can understand it in terms of trying to prevent a febrile neutropenic event. I have no trouble with that. I don't think, though, that increasing neutrophils would prevent a viral infection or help you manage a viral infection. And again, those patients that go on to develop ARDS with COVID, there's a significant amount of neutrophilia within the lungs. The lungs are packed with neutrophils, and I would not want to worsen that, I guess, in those patients. I really worry about the use of growth factor just to keep neutrophils up.
I agree.
Okay. The reason I ask is that when sort of COVID started, this was one of the, I guess, discussion points that came out. Should we be using more GCSF in our patients? Anyway, so I appreciate your responses to that.
We weren't doing that certainly within the breast group at Princess Margaret. I don't know about any other groups. I think the pharmacist would have been quite concerned if we were doing that in outpatients and all the extra discussions and trying to get compassionate use. So we stuck with the guidelines.
Very good. Okay. Does anyone have any other questions? It's pretty, we have a lot of attendees, but a very quiet audience today. That's okay though.
It's Nelisco. Can you hear me?
Yes.
David, first of all, congratulations on your retirement.
Thank you.
I recall before a lot of this stuff was around, occasionally you'd have problems with nausea, protracted nausea with people, and nabilone and things like that were used. Is there a role for those sorts of things given all the tools in the toolbox right now?
That's a very good question, Neil. Martin Stockler in Australia was one of the authors, I think the senior author on a study that I'm not sure if it's been published yet, but it was technically a positive. Yes, it would have been. I wrote a commentary on it. It's technically positive, but they used a mixture of THC and cannabidiol, and about, I think, 30% of patients had moderate to severe side effects. So they had a somewhat better result. Oddly enough, a lot of them preferred being on that agent. Kind of hard for me to understand, and we wrote that in the commentary. So I think there could be a role for the patients who have profound problems with nausea or vomiting, but what I wouldn't want people to do is to start putting that in when you have a proven approach like olanzapine that certainly in very low doses now seems to be pretty well tolerated and is quite effective. So there may still be a role for it. And the study by Martin Stockler et al. Is perhaps a start, but the toxicity issues still have to be worked out. And they had a population that had fairly extensively used cannabinoids before, and they took a very long time to recruit the patients at centers that were very good at recruiting to other studies. So it's a minor role, and I wouldn't want to see other more proven agents set aside for that, even though it's more trendy.
Yeah,
Thanks.
as you know, yeah, thanks, David. I would agree. Neil, as you know, we have a cannabis consultation service at the center, and we get asked about that a lot, and we discourage it because, as David said, there are better agents, traditional agents, and the other issue, at least, well, the other issue from our perspective is that with the consultation service is that we prefer that patients get a supply that's from a reliable source, and that's not always the case. And so we want patients to make sure they're accessing cannabis from a reliable source. And that can sometimes take time, potentially if you're looking at medical grade versus what's available out in the market for recreational at the Ontario Cannabis Store. So I think we just have to be careful about how we recommend these products to patients. And there are our standard therapies are so much better that we discourage it.
No argument.
All right. Thank you for that question.
I suppose one of the questions the audience might have asked are we all wearing our pants? And I can tell you, I can show you, I am. I'm not wearing the shorts.
Hilarious.
I'm actually not, just in case anyone's interested. Yeah. I'm at work though too, so that no, I'm kidding.
Is that why you have the door closed, Mark? Is that it?
That's right. That's right. That's terrific, guys. Okay, I'm going to bring up the polls again. So I'm going to relaunch, and
I think I could only go down. So if I don't go down, that means, Carlo, you lost. You definitely
That's
lost.
absolutely, yeah. Well, I knew the odds were against me right from the start.
okay, I'm going to relaunch the poll. So please start your voting. I'm going to give it about another 10 seconds. Okay, so when we have repolled our attendees, so originally the yes/no ratio to question one was 81% to 19%. So 81% agreed with the statement, 19% disagreed with the statement. So we do see a bit of a switch closer to the disagree statement. When we look at the second question, the split was 69% in favor or in agreement with the statement and 31% not. This has clearly changed to 87% in favor versus 13% not in favor of this or in disagreement with this. All right. I just wanted to say thank you to both the speakers for an exciting and entertaining debate and rebuttals and insight into the questions that we had. Other than that, I thank everyone for attending. I think it's been an excellent turnout. We had, I think, up to 50 attendees at one point. Many have sort of snuck off back to work probably because they have other things that they're responsible for. But thank you everyone for attending. Thank you for organizing, Dr. Chow. And wonderful to see everyone attend.
Thank you, everyone.
Thank you
Have a great Christmas, David. Take care.
Take
care.
Take care. Bye.
You're on mute.
I was just gonna say thanks. We should do this more often.
Yeah, we should do this more often. I agree. Totally.
Okay. Well,
Right.
I'm gonna come in now because
Okay.
I was just doing some project stuff in the morning. But
Sure.
okay, just let you know. Thank you. Bye.
Okay. Thanks, Maria.